Welcome, everyone. Thank you for joining us. My name is Lillee Gelinas, Editor-in-Chief for American Nurse Today, the official journal of the American Nurses Association. I'm also Senior Fellow and Nurse Executive for Safer Care Texas at the University of North Texas Health Science Center. I'll be serving as webinar moderator. Our topic today is CNO-CFO Partnership Achieves Successful Patient-Centered Staffing. Patient-centered staffing isn't a luxury. It's essential to the financial health of an organization. Today, two leaders from Phoebe Putney Memorial Hospital describe how they worked with a cross-functional team to implement patient-centered staffing. We thank them for their time and valuable information. This educational program is brought to you by API Healthcare. We thank them for their support. Our plan for today: discuss why patient-centered staffing is vital to an organization's success. Review a case study of how a system successfully implemented patient-centered staffing. Describe how the partnership between the Chief Nursing Officer and Chief Financial Officer was critical to success. Our panelists today are Evelyn, Olenick, and Brian Church. So let's begin. Welcome to Evelyn and Brian.
Thank you, Lillee, for that introduction. We wanted to start with a little bit of detail about the Phoebe Putney Health System. We're located in Albany, Georgia. We have two hospitals in Albany, Georgia. We also have a couple rural hospital locations. We have one critical access hospital, and we have another 75-bed hospital. We serve about 500,000 residents in a 41-county region, mostly in southwest Georgia. We've got about 792 licensed beds. We provide advanced oncology services, cardiology, and surgical services. We've got about 4,500 physician, nurses, and professional staff and volunteers throughout our health system. To give you some of the specifics on our numbers, we have about 22,000 admissions a year, about 2,600 births a year, and about 112 ER visits. We are a not-for-profit, community-based health system. Some of the challenges as we took on this project that we evaluated here at the Phoebe team were that we realized that we had some high overtime. The main symptom of that was inconsistent staffing practices and a lack of transparency across the organizations. We had a number of staffing units that were doing their staffing in silos because they did not have access to the overall global view of what was going on in the hospital. We had some staffing software solutions that were in place, but only a few of the units were using that technology very well. In fact, many areas were only using a partially built system, or they weren't using it at all, and instead were relying on backup paper schedules. And while a central staffing office was in place, they only handled contract labor. They did not operate 24/7, so we had a very inefficient, ineffective practice. We were obviously getting the unit staffed, but we weren't able to really see the holistic view across the whole organization. And Evelyn and I realized that we needed to address that challenge.
So our initiative goals as we designed what this project needed to encompass, first and foremost, we definitely needed to reduce our overtime spend. We recognized we needed to standardize the processes for scheduling and leverage the functionality of the existing workforce management solutions. We also wanted to establish the central staffing office as a hub, and although we had an office, as Brian identified, it was not functional 24/7. We also wanted to boost staff engagement and make certain that they were very well involved and enmeshed in their scheduling and being participant in that schedule as well, because we know that drives staff satisfaction. So we had developed what we recognize as the cross-functional initiative, and we knew that it was going to require definitely nursing and finance to be partners throughout this project. So Brian and I were the executive sponsors in his role as the Chief Financial Officer and in my role as the Chief Nursing Officer. We convened a team that included nursing representatives, finance, and performance excellence leaders to develop a Six Sigma Black Belt project that would focus on reducing overtime expenses as well as developing better scheduling processes and greater transparency. So it really was a true partnership. it was a partnership between the chief nursing officer and the chief financial officer. And that was very critical, that Brian and I were overseeing this project together, that we were both at the table, working together to lead the team. Key decisions around policy changes for staffing and scheduling were jointly made by the CNO and the CFO together. And then with both of us leading the team, there wasn't ambiguity around next steps. So we would meet frequently with the leaders of the Black Belt team, and we would have progress updates as well. And so the CNO and the CFO partnership at Phoebe definitely proved that labor processes can be improved, which in turn improves RN satisfaction and improves overall financial performance, because you can't have one without the other, and recognizing that the financial improvements and our performance definitely rests not only with the staffing, but truly patient safety, ensuring quality outcomes, having an exemplary patient experience while maintaining a staffing workforce.
So in terms of Evelyn's comments on partnership, I think I would just add to that that I felt the only way this project would have worked is if we had a very strong partnership between Evelyn and myself. The teams prior to this, in terms of both the nursing leadership and the financial folks, were kind of operating in silos themselves. So getting clear direction from Evelyn and I from a partnership perspective, each of us providing the same direction and each of us wanting to solve the problem from the same direction, I think helped the organization get some clarity that we were going to focus on trying to improve the scheduling process, but also try to reduce overtime. So it wasn't so much just about cost or just about nursing scheduling. It was taking the two together and painting that vision for the team, which I think was very, very helpful. So in terms of our partnership and how we would start with standardization, I would recommend a few things. As we looked at overtime, we know it can lead to staff burnout and turnover. Making better overtime management the key success factor from both a financial and a staffing satisfaction perspective was important to us. We didn't want to just focus on one or the other. We recognized that we had inconsistent and siloed staffing processes that were the root cause of the issue with overtime. The team focused on improving and standardizing that scheduling process. So it wasn't just about reducing overtime. It was also about how can we help standardize this for the nurses and the nursing leadership. During the review of the time and attendance and staffing schedule policies, our team found an outdated attendance policy that needed to be updated. By updating that, we were able to reduce the number of call-outs that employees were allowed through the policy. It was a very generous, liberal policy. By working with human resources, we determined that our regional Georgia hospitals were much more stringent in their allowed absences. So Phoebe, we didn't go the full way that our partner hospitals did, but we revitalized our call-out policy to make it just a little bit more stringent, and we saved about 33.8 nursing FTEs. Those are FTEs that we were able to put back at the bedside simply by using our existing staffing more effectively. And the teams appreciated that. As we did some of our Six Sigma work and actually interviewed the frontline nurses, their feedback to us was that they didn't like that their co-nurses would call out and then put them at a higher ratio, maybe 5-to-1, 6-to-1. They really wanted a more consistent playing field for the ability for folks to call out and really support the team at the nursing unit level by having fewer call-outs so that there'd be more predictability with the staffing. So there was a technology component to this project, but there was also an HR and looking at the policies and processes and making sure that we were putting our nursing staff in the best position to be successful.
So as we looked at our integrated system solutions, although Phoebe had an automated staffing and scheduling system installed, the usage was limited as well. It was variable. So this lack of solution standardization and the use of a paper-based process resulted in inconsistent staffing practices, limited visibility into the staffing needs, and units really were staffing in silos. So after much consideration, we decided to deploy the API healthcare staffing and scheduling solution throughout the entire system, including the API healthcare time and attendance, as well as the API healthcare payroll and human resources to support our go-forward strategy. And the central staffing office, this is where the census and the number of staff, can be actually seen in real time. So having an approach, using the right technology to leverage those resources so that we can make decisions in more current time, having information with admission, discharge, and transfer, that census, being able to capture what the overview of our nursing units that are experiencing through patient flow and the volume, and being able to make real-time decisions. We also implemented the mobile app, and it has been very well received, and it also has the ability to provide those more real-time solutions as well.
Absolutely, Evelyn, and part of the technology rollout was sitting down and looking at all the departments that would have to be changed, and I think that was a very eye-opening experience when we sat down with the team and said, okay, we're going to roll out this solution, mandatory, make it mandatory across all the units and all the departments. There's a lot of employees here that are going to have to be educated and trained. So what our team decided to do very early on, and we would recommend this, is to prioritize how you deploy the new software or new tools, especially in a system our size with 4,500 employees. We just had a very limited amount of capability in order of getting that new system rolled out. So, with the priority of addressing overtime, the strategic system rollout began with the inpatient nursing units and associated cost centers such as lab and pharmacy. That was really our focus. We knew better overtime management was our primary focus, so when we created out our rollout timeline, it made sense to start with the areas that had the potential to realize the biggest overtime cost savings. So that's how we kind of took that list and prioritized it to where we would start. Within just 1 year, the team had completed the rollout of 171 of the 299 cost centers that we had identified that needed to be restructured. With the 2 campuses going live here in Albany in one single phase, because of the focus on these areas with the highest overtime, we had the ability fairly quickly to impact about $7.4 million of the $9 million in annual overtime expenses by starting with the areas with the largest overtime expense. The rollout to 57% of the units allowed them to manage 82% of the overtime cost potential. So we would definitely recommend, if you take on a project like this, that you do the data analytics to see really where your overtime spend is, where's the biggest opportunity, so you can get those quick wins early and show the organization as you roll this out where the benefit is, and then it becomes much easier once everybody sees the why and the actual benefit.
So while we already had a central staffing office in place, the team had a vision for restructuring the CSO to provide even more value. They made the central staffing office the hub of efficiently moving staff to minimize agency and overtime while always keeping an eye on patient care needs. And again, it's all about patient-centered staffing, being able to ensure that we're using the right evidence-based tools and right evidence-based guidelines. So as a central hub for nursing, the CSO team fills any staffing holes that remain once the schedule is published and can be broadcast for critical needs of a particular unit. So staff are also able to view the monthly view, which allows vacancies to be picked up when available, additional time, and it allows the leader then to make the most prudent decision with regard to an employee who may be in overtime or premium versus someone who is in straight time. And so with this global view of staffing needs, the staff can absolutely effectively move resources around as needed, again, based on patient acuity and based on skill level and based on the activity of what's going on that particular nursing unit. And this end result of the transparency, the ability to cancel agency, that wasn't necessary and reduce overtime, it also contributed to that $2 million reduction in the overtime. And then Phoebe also moved from managing staff licenses with a paper-based system to an electronic system. So by utilizing this licensure feature in the API staffing and scheduling solution, the CSO is able to be a centralized resource for tracking and managing any license that is required, obviously, for the registered nurse as well as the licensed practical nurse. And this also includes tracking for initial competencies, which is due at 120 days of starting or transferring into a new position along with their annual competencies. So it is a way to have those alerts built in and pushed. For instance, basic life support and advanced cardiac life support cards, competencies, licensures, all that have that annual renewal due date. This information now is pushed out to unit leaders so that they're able to stay on top of the licensures and competencies proactively, rather than each unit trying to manage paper files and scrambling to stay on top of due dates. And recently we had one of our regulatory surveys, and nursing was able to readily produce the information at a moment's notice. And that was also very well received by the surveyors. Again, it's a way for the central staffing office as well as our leaders to stay on top and be proactive with needed competencies, licensure, and requirements for jobs. So this does create greater transparency. Creating transparency was critical to our strategy. By making sure that the right people can see the right shifts, this empowers the frontline staff and leaders to stay on top of staffing as opposed to staffing in silos, and it enables the central staffing office to take a broader approach to staffing. Because leaders have visibility into shifts and staff availability, they can make informed decisions about who is the best resource to pick up an additional shift. And Phoebe, we use a combination of self-scheduling and track scheduling in certain of the units. And in this way, they can provide nurses with scheduling predictability and flexibility, and that in itself is a staff satisfier. As we work with a multi-generational workforce, we absolutely know that staff want that predictability, they want that knowledge, and they want that control over their schedule, but they also are mindful of the organizational and patient care needs as well. So with the new staffing processes, this has also resulted in a higher pickup of open available shifts. With more awareness about staffing holes, staff and nurse leaders can now take a more proactive approach to filling any shift vacancy in advance of the shift. And again, it's all about being proactive and not waiting till the 11th hour when you absolutely are in that crisis situation.
And based on some of those key elements that Evelyn just reviewed, some of the benefits and outcomes that we've been able to realize, because the staffing and scheduling is now better managed, the central staffing office team have the ability to use a more consistent approach to produce nursing labor budgets for the next fiscal year, which has given us some more consistency and accuracy in our budgeting process. With better data, easily accessible, the team has a better understanding of the needs and opportunities as they set their target FTEs during the budgeting process. So it just creates a more consistent projection month to month, but year to year, of what our labor needs are going to be based on certain admission points. The process improvement work as well was very well received by the senior leadership team and will continue going forward. This was a real good win for our relatively new lean processes. The attendance policy opportunity calculation was based on reducing our call-outs by about half per the new policy and converting those days into at-the-bedside FTEs. So we, as we mentioned before, I believe we captured about 33.8 additional nursing FTEs back into our schedule that were really lost because of inconsistent call-outs and not having accountability in that process. For our project, this was presented as an opportunity to substantiate our policy revision, but not a final impact. So we continue to work this and listen to the nursing leadership team about what tweaks we need to make to our attendance policy to kind of strike that balance of making sure that we've got people here that take care of our patients, but also being responsive to people that have needs to have reasons for call-outs. So overall, we think a very strong benefit and outcome from our work.
And so as we identify the additional benefits, this was access to better information for nursing labor budget creation, as Brian has just identified. We have used this to meet annually to do our projections forward for the next budget season. And we also recognize that it increased staff engagement, increased the control over the staff's involvement in their scheduling. Also, using the mobile technology was definitely a benefit, and it was an added improvement in their involvement. Also, with leaders can use the app to provide remote approval for schedules, and that in itself is another way to leverage the technology while you don't have to be necessarily tied to the desktop. So as Brian identified, it's preparing for budgets. When we've met annually, and that includes myself, it includes Brian, it includes our nursing team, our central staffing office, finance, as we look at our benchmarking, our projections for what we're going to see in the next budgetary year, as well as using evidence-based guidelines to really identify what is it that is unique about this particular patient population, this particular nursing unit, and why we need to make staffing adjustments. And as we look at going beyond what is the future, this will require going beyond those traditional staffing models with disruptive thinking. And I say that because we continually need to refine our staffing and scheduling practices to accommodate a multi-generational workforce. We need to be mindful and to balance the organizational needs, patient care needs, with the bedside staff's desire for flexibility and mobility. And we need to evaluate future models for demand-based staffing using acuity and predictive analytics as we look at that what's next. Because even though we found the API solutions to be very effective, we always are in that mindset of evaluating and making it better and partnering with them to, again, create the best ability to provide patient care and using patient care-centered staffing and using the foundation that we have to leverage the technology to help nursing leaders, to help our central staffing office make the best decisions possible. We implemented a command center this past February, and so this platform has been very helpful as we look at our patient flow, as we look at demand-based scheduling at a future point, as we look at the complexity of what our workforce is and ultimately what our patient care needs are. So it has been very effective, and it truly has been a partnership with Brian Church as our Chief Financial Officer in moving these initiatives forward, because it is that partnership. As I have to translate the business of care into that financial outcome, it is the ability then for Brian to seek to understand, to then bring the financial aspect into the patient care world, and we blend these two worlds together to create our patient-centered staffing and to always keep the patient at the forefront of everything we do to achieve that world-class care with our hometown commitment here in Albany, Georgia. And now I will turn it over to Lillee, our moderator.
Thank you, Evelyn and Brian. Before we get to your questions, I wanted to let you know that an upcoming special section will be in the September issue of American Nurse Today. This new resource will include success stories and even more information for you to read about related to patient-centered staffing. So thanks to all of you. We have a lot of questions to get to, and we'll get to them as quickly as we can. I believe the first one is for Evelyn. Evelyn, experienced CNOs know it's almost second nature that having a strong relationship with the CFO is important. What advice would you give to the novice CNO or someone aspiring to become a CNO in developing a strong relationship with the CFO for patient-centered staffing?
Thanks, Lillee. Well, I think the first thing, the CNO and the CFO relationship requires mutual respect and commitment to understanding each other's roles. The CNO has significant responsibility with regard to not only clinical and quality performance, but to financial performance as well because of the salary impact that nursing has in any hospital. Experienced CNOs understand this is a very important working relationship and that neither nursing nor finance can succeed independently. So the novice CNO and those aspiring to the CNO role need to understand the significance and importance of developing a very strong, collaborative, team-based relationship with the CFO and the finance division. Working as adversaries or in silos is definitely ineffective, and it's a recipe for disaster, and you will never be able to move your strategic initiatives forward. So how do you approach this working relationship? So my advice is you have to seek out the necessary financial knowledge, speak with other colleagues, seek out evidence-based information about patient-centered staffing and the relationship to outcomes, resource utilization, workforce optimization, to name a few examples. Share this knowledge with your CFO and commit to being partners in addressing issues that cross finance and clinical outcomes. The CFO should have as much interest in the workforce as the CNO because of the salary impact and patient outcomes and this translation to overall cost. That would be my advice. Brian, what is your advice to developing a strong CNO-CFO relationship for novice CNOs or those aspiring to this role?
Yeah, I mean, I would agree with everything that Evelyn outlined, and I think I would add to it just an example today. Evelyn and I this morning at 9 a.m. Rounded together on a couple patients that were some key patients to our institution, some very important folks in the community. We try to do a lot of things together. We don't always agree. There's not always going to be that situation where both of us see the world the same way, but we're always willing to close the door and have those hard conversations with each other. And I think you've got to be able to do that and recognize that you're both going to see the world from a different lens. And I think Evelyn and I are able to, no matter what the problem is, whether it be scheduling or contract nursing, we're able to sit around the table and at least express to each other our views and then try to solve the problem together. And I think that's what I would recommend doing.
Brian, thank you. That is very key, that when we have that relationship where, as Brian said, we can close the door, we can agree to disagree, but when the day is done, when we, exit out of that door together, we are one team together. And that's important for any formal organization, the mission, the vision, the values that we're really supporting, because as senior leaders, people look to us to help solve the issues and remove those barriers. And that relationship is absolutely key in any successful organization.
So visually, it sounds like the outward representation of the relationship is the role modeling and walking the talk. And when you might have issues, that's the inward relationship where you do it one-on-one, which can actually build the relationship, but it's not role modeling conflict as from an outward standpoint. So it sounds like you really have that outward-inward balance that drives your success. Evelyn, the next question is for you, and it's a good one. Did you encounter resistance from your nursing leaders in giving up total control over their staffing and scheduling practices? Because, that can be, if it worked well on their individual unit, but it's not going to work for the whole house, how do you balance that? So talk to us about resistance or maybe lack thereof from your nursing leaders.
Well, I would say instead of resistance, it was probably more that element of trepidation. Will I have the resources? How will all of this work? Well, what if there's a last-minute call-out? How can the central staffing office take care of my needs on this busy acute inpatient unit or critical care unit? So there was more of, I would say, that trepidation. I'm very proud of the team because they worked through a number of issues. But what is key, absolutely, and first and foremost, is communication. Communication of what the vision was from the CNO's perspective, the CFO with regard to, as we embark down this journey, creating the central staffing office to really help provide our frontline leaders the necessary support, because we all know that the frontline nursing leader has one of the most difficult jobs in the organization, and they're balancing resources in real time. And it is extremely important that they have the support. So building the CSO was also a way to give them the tool so that they can better visually manage their unit, be visible, taking care of the critical elements. And of course, there still is that management of the resources, but it was important to have that communication, and have them, once we had worked through the process, have them at that table to react to, is this going to meet your needs? And then we continue to fine-tune it. Our central staffing office meets with our leaders, continuing today monthly, because we always want to optimize and make it better and have that support that they need, and to identify where they still find those barriers. So, to say resistance, I would say it was more of that fear factor of, gee, I don't know, will you be able to support my needs? And where there might have been, I would say maybe a little resistance, it may have been someone that experienced at a prior time maybe a lack of support. So we had to rebuild that trust and show them that we can really support their needs in a better way.
So how would you describe where they are now? Is the fear factor been abated, or they have confidence in the system? That's what it sounds like to me.
It's definitely, they have confidence in the system, and I think they have a reliance on the central staffing office to help solve their staffing issues with them in partnership, especially around call-outs and managing those last-minute changes or an influx in volume, where they can definitely broadcast the needs, eliminate this task from a leader that is already managing multiple issues on their unit, and being able to offload some of that. It's an essential task, but having someone else, provide that supportive role, and they're able to react and help balance those resources and agree. Definitely giving the input on what type of skill level that is needed, and the amount of patients, because the ADT, or Admission, Discharge, and Transfer system, is continually, about every 15 minutes, it's getting refreshed with what the more accurate patient census point is. So to answer your question, Lillee, I would definitely say they have a high reliance on it, and they work together as a team to continually perfect the support that the CSO can provide to our nursing leaders.
I just think that's a wonderful success story. If I were writing a headline for it, it would be Resistance to Reliance.
I like that.
Brian, resistance to reliance, that's what you've been able to demonstrate. Brian, we have a question for you. How did changing your attendance policy save you 33 FTEs? Can you talk more about that?
Sure. And that's a good question. When we started this project, we didn't set out to change our attendance policy. It actually came up in a meeting we had when we were using our process improvement folks. We pulled in HR, we pulled in some frontline nurses, we pulled in some nursing leadership to map out the process during a whole day session of how our scheduling worked and how were ways to improve it before we started down the path. And what came out of that, we were actually very surprised, both from nursing leadership but also from the nurses, at least I was surprised, was they felt that we weren't supporting them from an administrative perspective because our attendance policy was potentially too liberal in their view. And allowing people to last minute call out X number of times without having any accountability from a performance review perspective or putting in any corrective action plan. So we actually kind of, after that, set up another group and had them benchmark to hospitals in our area, because we didn't really know where we were, and we didn't want to make any quick decisions. So we reached out to numerous hospitals in our region and said, what is your attendance policy? Will you share, how many allowed unexcused absences are allowed before, you have a corrective action process? And we got that data, pulled it all together, and a recommendation was generated by that group, which was a mix of HR, nursing leadership, and a financial person, that we should change our attendance policy. And the way the calculation actually works is it's the attendance policy opportunity calculation. We base that on reducing the call-outs by a half. So if we could reduce our unexpected call-outs by a half, our central staffing office would be able to add 33 FTEs to the schedule and keep them there without having to backfill them with either overtime or not having them filled altogether. So it's really not a financial savings, but it created more stability for our frontline nurses, and instead of having to see their ratio go from a 5-to-1 to a 6-to-1, and add stress to their workload, they were able to be more assured that they would have proper staffing on their floor more consistently with the updated attendance policy.
That's terrific, and I bet we get a few more questions about the attendance policy, but I think many hospitals are struggling with that. What's the balance around the attendance policy? But reducing the call-outs by half, wow, congratulations on that. Brian or Evelyn, I don't know which one of you want to speak to this one, but when you're talking about the real-time decisions, and Evelyn, you just mentioned the system refreshes every 15 minutes, how do you get your census file uploaded into TASS? So maybe you can explain that too. Which one of you
Well,
want to
it looks, the TASS to me would be the time and attendance system for, I think, the individual that submitted this question. And as I said, the admission discharge transfer feed gets uploaded every 15 minutes. You know, with our API, they've worked the flow process that way. So, you know, it is more accurate in real time. And of course, the schedules, everything is loaded. So it's about as current as we can possibly make it. I don't know if we can condense the time any more than that, but I think that's pretty appropriate. And Brian, from your perspective, with what you're seeing, because, you know, from the revenue cycle and the finance with admissions, discharge, and transfer, I mean, that feeder flow moves pretty much in real time.
Yeah, and I would say, it wasn't in our presentation, but you probably would want to know, I mean, I would say more important than how often the census file gets uploaded to that system is the fact that we have our central command center, which we do some predictive things where X times a day we look at how many patients are holding in the ED, how many patients are going to have their surgeries completed and have to go from the PACU and have a need for a bed. So I think we've probably taken it one step further, and probably not the intent of this webinar, but with our central command center, we're looking at metrics even ahead of what our actual census is today, or at this moment. We're trying to predict now, you know, when beds are going to be needed and how many shortage of beds we're going to have on the ICU or on our general medical floors. So we kind of have a couple different systems that help us do that with the staffing.
So would you say it's done, in answering the question, you've got real-time decisions refreshed constantly, but it's all operating in the background because of what you discussed, the integrated workforce management system, so time and attendance and staffing and scheduling, and the ADT system, it's all automated. Would that be correct?
I wouldn't say that it's all automated and seamlessly works together, and I think that's why we've had to have the central staffing, and we put it into our central command center for our hospital so that we can have all that information in one physical location. So, you know, we know how many call-outs there have been. We know how many surgeries are scheduled for the day. We know how many patients are sitting in chairs in the ED or are holding actually for an inpatient admission that have inpatient orders written. We've got a plethora of that data available to us in our command center, which helps with the staffing.
So there is a related question about the command center, Brian. So could you clarify the command center operational role, and is it the same as your centralized staffing office that you mentioned, the CSO, I believe, if I remember that slide correctly?
So our central staffing office is located in our command center, but our command center function is really a central point for throughput through our hospital, and also in instances of emergencies becomes the command center for the whole health system, and it has separate dedicated space for that. But on a day-to-day basis, we're using teletracking as our tool for patient throughput, for monitoring patients as they flow to diagnostic testing, as they're discharged, as they come onto or admitted to a unit. What our available beds are that are clean or dirty or blocked for an infection reason or a one-on-one. So I think what was brilliant was when Evelyn married up the central staffing office with that command center throughput function. It allowed that central staffing office to have access to so much information that could help them actually look forward to the night shift, look to the morning shift tomorrow. What are our demands going to be based on what we think our volumes and transfers into the hospital that are coming from other facilities? there's just so much data that's available to the central staffing office because of it being located in the command center.
This sounds like a terrific structure, and the outcomes that you're getting from it. Very obvious that the structure is in place and it's the right one for your organization. The next question says, first of all, thank you for this wonderful presentation of your success. You mentioned that the Central Staffing Office manager contracted labor. Were you able to appreciate a decrease in agency nurse usage or temporary staff usage? And if you were, by how much?
So my comment here would be, it's not so much that we were able to reduce contract labor, and I'm sorry, Evelyn, if I jumped on top of you, but what we were able to do was by centralizing it, we had multiple vendors that were providing us contract labor in an inconsistent way under inconsistent contracts. By giving it to one person and having a central person being able to work that contract labor, we did reduce our rate per hour, but also were able to get some terms and provisions because we were bringing the full scope of the business to one vendor. Is that what you would agree with, Evelyn?
I would definitely agree, and I would say, the true and accurate is, unfortunately, we did not decrease our agency usage, and we're very transparent with that because, we're like many hospitals, and especially in Georgia, we are one of the top 10 states that is targeted, and currently we're experiencing a shortage of nursing. So we do have to have that, reliance on purchased labor as well. And but again, that is no different than anyone else. But we have many actions and layered approaches to. We're always, trying to reduce our contract labor and increase our part-time and full-time nursing workforce.
But it does seem like you did have tremendous benefit if you had better agency use, reducing rates with fewer agencies, so you have tighter control. Is that fair to say?
Oh, clearly. Clearly, that was definitely and is definitely a benefit, Lillee. There's no question there. And as Brian said, as the team, the leadership who was, evaluating, our master service agreements, moving forward with, instead of dealing with, a number of different, vendors and agencies, dealing with the one and really making it more streamlined. And as Brian pointed out, we're able to, appreciate, reduced rates and tighter control over the purchase labor that we do have.
One specific benefit would be with the new contract and having it centrally managed, is that the central staffing office is able to monitor, the volumes and determine if we need to send contract nurses home. And we have X number of hours in our contracts, per week that we're allowed to, send those nurses home if the volume doesn't support it. So by having that process centralized, I think we're able to get to that conclusion because they're able to see the whole house and either move that contract labor, or if we don't need it for that day, if we're allowed to, based on the contract, send that contract labor home and not have to pay for that. So I mean, to me, there's probably some savings we haven't been able to calculate, but definitely by having it better organized and not managed by individual directors who might be at meetings or might be doing other, working on other patient care issues, that wouldn't be able to as closely monitor the uses of contract labor. At least as a CFO, I feel way more comfortable with what that central staffing office is, because that's their primary role. That they're not having to take care of patients at the same time, trying to manage, their volumes and their labor.
I was saying another way that we monitor it is that every 2 weeks we have a labor management committee that I'm a member of. Brian is on, a couple of our other senior VPs of operations, and we get these reports, in very real time. We'll be able to, react to where we might have a need, as Brian, articulated, and keeping that communication so when there are questions, you've got the right team of nursing leaders from the CSO, that group who is able to really identify why there was a need for a different staffing configuration or why the resources were needed. If we saw a number of nursing one-on-ones in our critical care units, we have a very robust 38-bed critical care high-intensity unit, And it makes a difference when you're dealing with patients of significant acuity, as well as trying to manage that against the volume and the resources that you have. So, it is key that we as the senior leaders have this information that we could react to right away and course correct as needed, and provide, the approval where we do need to have an increase in usage of staff.
That's fully understandable, but a key aspect that just strikes me is one of the reasons for some of the high turnover of nursing managers is they'll say that I spend more time on managing staffing than managing patient care. So if you have the centralized staffing function, they really are spending their time managing the patient care issues or the things that are important to the workforce on their unit. So I think you're right. There are a lot of benefits that you may have had that we just haven't been able to put a dollar sign to, but they are invaluable. Okay, I'll move to the next question here. How receptive is the CFO to evidence-based practice and benchmarks from professional nursing organizations such as NDNQI, the Emergency Nurses Association, the American Association of Critical Care Nurses, etc.? And if you do use benchmarks, what benchmark is used to establish overtime percentage?
So, the first question, we're always receptive to, what benchmarks should be. We also use external benchmarking tools. I'm sure everyone's familiar with, systems like Premier. We use Premier here in terms of our benchmarking to like hospitals. But we do for, women's and children's, for AWAN standards, we absolutely have those conversations in our budget meetings and want to make sure that we're meeting those where we can. In terms of overtime, overtime is always a little bit tricky because the way we do our labor management committee, and Evelyn mentioned this earlier, is every 2 weeks. And what we generally look for before we add new contract agency is, how has the unit been staffing itself up to that point? And if we've got nurses that have to have 2-3 extra shifts that we call schedule overtime, you get to a point to where it validates the need for a contract labor person, because you don't want to burn out your full-time staff and create a vicious cycle of adding more contract labor. So I wouldn't say that there's a specific benchmark we use, but it's one of the criteria when we're evaluating our utilization of new contract nurses. What overtime percentage has that unit been running, and how much scheduled overtime have they built into their nurses' schedule for the next 6 weeks, 12 weeks, 18 weeks, are all part of the conversation that we have. And what we don't want is to have nurses that are required to do overtime every single 6 weeks over and over and over for a short period of time. If that's something that we have to do because we've had 3 nurses leave on FMLA, or there's just been some real strange scenario, we're generally okay with it, but not long term, because we know that it'll generally lead to more turnover.
Well said. The next question is, does productivity now get de-emphasized over better scheduling and staff and manager happiness?
I guess my answer to that my answer to that would be I think in today's healthcare environment, I think you have to look at all of them equally, and I don't think you can de-emphasize any of them. I mean, I think if you focus too much on productivity, you're going to burn your staff out, your managers are going to get upset, and there's plenty of options elsewhere. They're going to leave. So what we've tried to do with our nursing ratios and our overall staffing is try to be very, very receptive to specifically new nurses that are new grads that might not have the same experience or workload ability. I'm not going to say we get it right all the time. I haven't found a perfect system to be able to help you do that 100% of the time, but we do have those conversations. I mean, productivity to us is important. It has to be, because if it's not, then you quickly can get in trouble financially. But I think just as important to us, and when we have our labor management meetings, we're talking about the staff burnout. We're talking about what the quality metrics are on the unit. We're talking about what the performance is. And I think you have to look at those other factors, patient satisfaction, to make sure if you cut a unit too much, you're just going to save some money, but you're going to have problems everywhere else, and that doesn't long-term work financially either.
Well said, Brian. And I was, earlier interjecting to say, absolutely not. We have to focus on productivity. It is not de-emphasized at all, because remember, as the CNO, as a nursing leader, we have a tremendous amount of responsibility. We have to ensure the viability that the resources are here today, tomorrow, and well into the future. And you cannot do that, to Brian's point, without keeping your eye on all aspects of the business. Absolutely, patient care. First and foremost is the most important. Do no harm, error-free care, harm-free care. That is the most cost-effective, but you have to take everything in the entire context of what you're trying to achieve. And finance is a significant portion of that, so that as the CNO, I can be assured that I'm going to have the necessary resources and the right, both capital dollars, operating dollars. And again, I have to be responsible to the productivity and managing the resources that we have on all of our units with our respective nursing leaders, and creating that outcome of good financial performance. And the CSO was one of the answers to help partner and to help them better balance. And again, it's a partnership. The nurse leader has not relinquished their role at all in staffing and scheduling. It's a partnership with our CSO, and the CSO is a tremendous support to our nursing leaders.
So I think in summing up that question for both of your excellent answers is, as you say, you have to look at all the metrics equally. It sounds like you operate with more of a balanced scorecard and are able to make some really important decisions in your labor management committee every 2 weeks. In our small amount of remaining time, we have 3 questions, and I'll try to get to all of them. The first has to do with how do you staff your central staffing office and command center. So how many positions, roles, FTEs? Just describe your staffing model for those two. The CFO
well,
and
with
the command
our
center.
Command center, we do have a dedicated VP over that role, vice president role. And that individual, also has responsibility for care management, also with the command center. And then partnering, the central staffing office component reports to an assistant chief nursing officer that reports directly to me, so that we have this matrix responsibility, so that we have the appropriate, relationship to nursing. And then with regard to distinct leadership roles, there is a central staffing office. There is a director who is over both the CSO and the command center, but respectively then each of those roles has a manager that is able to focus on the staffing and the scheduling, and then the manager that is focusing on throughput and the initiatives, with length of stay, throughput, discharges, transfers in. And then we have support personnel that are our shift staffers that work 24/7. And any more details with regard to FTEs, that could be taken as an offline, or you could email me for additional information.
Sure, thank you. The next point, I think, perhaps is maybe just a point when you were discussing the agency usage and how you were able to streamline your approach to it. But many reasons you may have to use agency nurses is trying to fill critical skill gaps that are hard to recruit. For instance, OR and critical care nurses may be harder to recruit in your market than other areas, or you just had recent turnover of those skills and haven't had a chance to recruit the experienced person that you need. So just as a comment there. Brian, what do CFOs expect their CNOs to provide as far as staffing data? We understand the need for financial justification, but sometimes just aren't sure how to go about it.
Sure. Great question. And I would say it's an evolution. I mean, Evelyn and I just had a meeting just yesterday with the Central Staffing Office team, talking about how we felt our process has come to a point now where we can actually implement some automatic processes and not having to come to labor management every 2 weeks around replacement of contract or new contract up to a core staffing ability. But what I would share just in an abbreviated couple minutes is when we look at staffing of a nursing unit, we're looking at the volumes, the patient days, we're looking at the worked hours, orientation hours, education hours, one-on-one hours. I mean, we really want to understand the full perspective of what's going on with that nursing unit and what the challenges are. What's the number of FTEs that are full-time permanent? What are the number of contract FTEs? How much overtime FTEs have you used during that time period? I think the best way to look at it is to not look at just singular points, but get it all together as you're presenting, what you need or where you're comparing. I always tell folks, I mean, a budget is a point in time with what we say a man hours per stat might be for a nursing unit. But if your volumes are up 10%, the hospital's probably doing really, really well. And I want you to have the staff to sustain that, not have to cap or send patients away. The economic benefit of having that volume is way more than the cost of having an additional 1 or 2 nurses. So I would recommend those factors. I mean, if you can show those and communicate those with your CFO, you'll be way ahead, and both of you getting on the same page of what your needs are.
Evelyn, is there anything you want to add to that with what you provide for staffing data?
No, I think Brian's absolutely spot on, and it's incumbent upon us as the leader to make certain that we know our business with regard to the hours of care, looking at comparative data, having your evidence-based information, but also knowing what is going on your particular unit. As Brian identified, why is there an increase in perhaps nursing one-on-ones based on the acuity of the patient population that you're serving for that particular shift or those various days ahead? Or if it's assistive personnel and trying to reduce falls or patients that are at high suicide risk. This is necessary to know because you need to know the activity. Being able to quantify the activity goes so far when you're trying to explain to the CFO and make that business case. And these are data points that absolutely you have to know. The volume, the activity, the specific factors. I know Brian mentioned earlier that, if you're dealing with a number of nurses that are on leave, again, quantifying the amount of non-productive time that you were counting on for coverage, but for whatever reason isn't available. So it is definitely incumbent upon the leader to know their business inside and out with regard to the amount of resources they have, the skill level, and what is actually in relationship to the staffing needs and what they're seeing for their daily activity.
Well, I must say that there's no doubt about it. In the last hour we've spent together, that you've clearly demonstrated that the Chief Nursing Officer, Chief Financial Officer partnership has helped your organization sustain, not only achieve, but I would say sustain, successful patient-centered staffing. So thank you, Evelyn and Brian, for a robust and fact-filled, informative webinar that helps us all understand how we can do better. That concludes our program for today. If you have questions that we haven't been able to get to, we'll be happy to answer them. Feel free to send them to the email that's on the screen. And thank you again, Evelyn and Brian, for sharing your insights. For all of us at American Nurse Today, thank you for joining us. I'm Lillee Gelinas. Have a great day.